Practitioner responsibilities. Now, again, practitioner are those diagnosing, prescription writing individuals. They must be assigned an EMR encounter. So when, and this is not necessary for a nurse only or paramedic only visit. When you have a physician or a practitioner that's taking care of a patient, that patient is going to be assigned to that practitioner. There's a spot here for nurse only, paramedic only visit. What we found is that, one, we wanted to ensure that there was a practice that everybody had an appropriate diagnosis as well as a discharge note written. And then what we found is that we'll make that be a physician that needs to do that, because as we said, they are overall responsible for the entire care of that patient. Well, we were told that there's instances where you might have a fast track, or you might have somebody coming back for a blood pressure check or a wound check, that if you're in a really busy center, that a nurse or a paramedic might just be running that little session or that little section, and that a physician isn't involved, but yet we want to be able to capture something very close to that. And so what we did is clinical impressions. And so I'm going to talk about clinical impressions in a little bit, but a practitioner must be assigned otherwise if it's not a nurse or a paramedic only visit. The attending practitioners, again, practitioner, the diagnosing prescription writing person, are solely responsible for validating orders. We're going to talk about verbal orders in a little bit. My basic tenet is don't do them. Have the physician put the orders in. It's frowned upon in fixed facilities. I know that in a disaster environment it gets very busy, and if a physician's busy, he might start shouting out things. But ideally, we would like the physician to put in, or the practitioner to put in their orders. But at the end, if orders are put in by other people, it's the practitioner's responsibility to validate that that was done correctly, just as you would do in a fixed facility, and have that person initial or sign off that, yes, indeed, I did yell these out in this emergent situation. Enter a diagnosis. They must be logged in, and you're going to find out this week, if you haven't used EMR before, that you're going to have a login code, and it's going to identify you as a nurse or a dentist or a doctor or a physician assistant or a paramedic. And every time you put an entry in, or you type something, or you click a field, it's going to annotate it with your name, time, date stamp. So you want to make sure that that's taken care of. And when you enter a diagnosis, again, you have to be logged in as the physician to do that. Entering procedures, at a minimum, name of any major procedure performed, below the knee amputation, full procedure note when resources allow. Again, right now, unfortunately, we didn't have time to do procedure codes, or to do a quick procedure codes in the electronic medical record. The clock just ran out. But we want to make that, I guess, in future versions to be able to do that. So, as Tier 2 experts, need to make sure if you just saw somebody coming back from having a surgery done, or having some suture repair or something done, that just make sure that when you check that record that somebody put a procedure note in. And again, practitioner responsibility overall, but everyone, we're a team, everyone can kind of look out after each other. Discharge orders, discharge to home, transfers, physician, practitioner must do that, the discharge order. Dispositions, and this is the point too, where if you discharge, you can put to the location, but if you transfer, that's where the JPATS piece can come in, and you can say you're transferring this person. You can put the tail number of the plane, you can put the ambulance number, and you'll go into that further in the week when you're doing the JPATS piece, but at that point, that's a requirement of the disposition piece. And ensuring the medical record is complete and accurate and reflects the care given. Practitioner's responsibility, but we're a team, and let's all kind of help each other out and make sure that everybody's going to be overwhelmed with whatever their responsibilities are, but let's just make sure that the documentation on the patients is complete. Clinical impressions, I talked about this, used only when a practitioner is not involved with the patient visit. And It uses the National EMS Information System codes. So when we have these fast tracks, or we have a strike team, and I have here NSSEs, if you're familiar with those are the National Special Security Events. Those are the things that we do all the time on the National Mall. Right now we're in the middle of doing the Cherry Blossom Festival every weekend, that either Public Health Service officers or NDMS teams go out and actually set up a small little treatment center for people that are out on the National Mall all day. We do it for the 4th of July, we do it for the inauguration, for State of the Union, we do it for all kinds of things. So if you're in that situation and you don't have a practitioner available with you, if it's just an RN or a paramedic team, then you would be using those. NEMSIS codes. Also, internationally displaced person camps. We found that in Haiti that we sent small strike teams out, and sometimes there wasn't a practitioner with them, and we went out to those encampments where there were thousands and thousands of people, and we're just rendering very basic first aid. There shouldn't be a reason why we can't capture that, but you don't have a physician there with you. So now we can use those clinical impressions, and then you can put a clinical impression in there of what it was that you thought was wrong with this patient, because practitioners can diagnose, but providers cannot diagnose. And so doing this clinical impression at least gives us a data element of what was done with that person. Case management. Chuck talked about April Cady, who is the New Mexico 1 supervisory RN, and she was a nurse that deployed to Haiti. And it started to become a little overwhelming for me that about 2, 3, 4 times a week I was getting calls or emails from AOs, team commanders, or the actual person that had an issue coming back from Haiti. Hey, I turned up positive for tuberculosis. Hey, I stuck myself with the needle, and HIV is prevalent in Haiti. What do I do for follow-up care? Hey, I had bug bites and now I have a fever and my doctor says I have malaria. What do I do now? It was starting to become unmanageable to try to individually take care of all of these people as the chief nurse. So we spoke with NDMS leadership and OPEO leadership, and we activated April from her to her intermittent status to become our responder safety and health case manager. Now, a lot of times she wasn't, the person hadn't been seen in the EMR, and so she actually, we built a whole new facet of EMR, the occupational medical record, and she was putting entries in there, going by what the person told her and going by what little documentation they might have had from a hospital visit or whatever, or what they put on the workers' comp forms. April was able to use a clinical impression of what she felt was wrong with this person, because again, she can't diagnose, but we have a way now to go back into that and see how many people had a rash, or how many people, had some type of injury complaint. And so we can do that without her actually going in and diagnosing. So for me, it's a phenomenal improvement in the system. And I talked a little bit before about routine visits, the blood pressure checks, the wound checks, the things that you don't always need to have a practitioner come and take a look at something, especially if you're in a deployed location and that person's going to come back every day. You have your nurse, your paramedic team, they can put these clinical impressions. And this is just a list of some of them. I've got them on 2 pages. Most important down at the bottom, there were 4, again, when you're an EMR, these are going to be your options. So if you're logged in, not a doc, if you're as a provider and you're documenting something, it's going to do the Linda proof, boink, boink, boink. It's not going to let you put a diagnosis, but what it's going to show is clinical impression. It's going to give you all of these as potential picks. In there are those last 4, not applicable, not reporting, not known, not available. And they're already in the system. The computers are already imaged for this, and so we can't undo the not applicable, not reporting, not known. So the things that are others, which are the blood pressure check, the wound check, whatever is not included on this list, if you're a paramedic or a nurse, we want you to use that not available that not available selection, and then it gives you an ability to do free text, and then you can write in what it was. And that, it might seem trivial to you or just tedious to you, but when this actually gets compiled at a strategic level, we can go in and look at everything that was in the not available category, and it makes it much easier for myself, the chief medical officer, and his designees, and the fusion cell to parse that out so that we know, okay, they saw 80% were wound checks out of that, and we don't have to go into a bunch of different categories. So that's a business practice that we're going to ask you to please teach to people, to use the not available drop-down. Okay, how do you know the EMR is complete? And I just love it because again, it's Linda-proof. It's very, very smart. It doesn't let me push buttons that I can't push yet if I didn't finish something. And it's smarter now, and I'll let you know. And as I said, the screens, you can't advance them unless the required fields are filled out. And it will prompt you, and I was kind of hoping, Chuck, instead of having this EMR, that I could grab that little error box that says you did not fill out, and then it gives you the list of everything that you didn't fill out. But you'll see that this week when you're actually putting your hands on this electronic medical record. And time permitting, completion of all the fields in EMR allows for a comprehensive picture of the patient. We already talked about that. Very minimal fields that you have to fill out. But if you really want to do a complete record, and we're all clinical folks up in the chief medical officers or operational medicine branch. We know what it's like to be busy. But we also know that at the end of a deployment, when folks really want to look and see demographics and disease and whatnot, a more complete record allows you to do a better survey of what it was, what the impact of your care was. So if you can fill out the record, we love you for that. If you can't, then just do those minimal things. But we really appreciate a more comprehensive record.